My name is Meaghan Doyle. I'm a certified genetic counselor and I specialize in fertility genetics. And I'm the founder of DNAide Genetic Counselling. We are a independent genetic counseling group, which means we're not specifically affiliated with a fertility clinic or a PGT laboratory, which a lot of patients particularly appreciate since they feel like we don't really have a stake in the decisions that they make other than helping them find the decision that's best. I would define PGT-A's objective as a tool that can be used to prioritize embryos for transfer based on the likelihood that that embryo will lead to an ongoing pregnancy. I think that there is a overemphasis on PGT-A being a tool for predicting the health of the child that's going to be born, and that this is really poorly communicated to patients. This is much more about potential chance of implantation, potential chance of pregnancy loss. It's about ongoing pregnancy and that potential. We're really not supposed to be using PGT-A to assess health of the child that's born, but there have been multiple studies that have shown that when patients are surveyed, usually at least half of them think that PGT-A is supposed to help them have a healthy baby. I don't think that that's an appropriate use of this tool. So I think that we need to be doing a better job emphasizing what this is really for so that patients can have an appropriate expectation there. There's certainly lack of validation and standardization at PGT laboratories that could use some significant improvement, but I think there's also a significant lack of true informed consent from patients when it comes to the purpose of PGT-A, like we just mentioned. So, what can PGT-A actually accomplish for them? I think they're not informed about the complexity of the different types of results that we can get from PGT-A when it comes to mosaic results and even different subtypes of aneuploid results and what we're learning about the meaning there. And then also clinics' policies about which subtypes of results they will and won't transfer. There are consent forms, but there are so many forms to sign during the IVF process. So I think we have a long way to go to address the informed consent process and making sure patients understand what they're signing up for when they do PGT-A. In my ideal world, it might be somebody independent who's trying to get consent from patients regarding PGT, who isn't going to be making money from them doing that test. It might be a bit of a lofty goal, but I think when a PGT lab is getting consent or educating patients on the purpose, there can sometimes be a spin that they might put on what the test can accomplish. Possibly, again, at the fertility clinic, I would hope that none of those things are happening, but there is the option of having somebody independent walking them through the nuances of what PGT can and can't do. I do that sometimes with patients one on one before they're doing IVF, so it is really tailored. That would be quite burdensome for every IVF patient to have that one on one. But I think if there is something independent from the PGT lab, even if it's at the clinic, that would be at least a step removed from the company that's selling the product. I don't think PGT-A can ever be considered a diagnostic tool. It is absolutely a screening test. But I recognize that from a physician standpoint, it can be hard when you see anything, when the nomenclature is the same as a prenatal test, a pediatric test, an adult genetic test, to treat it differently from a diagnostic test. It is just hard to think differently about that result. But there's no doubt in my mind PGT-A is a screening test and we need to treat it accordingly. There are different subtypes of aneuploid results, and we need to recognize the nuance of what we've learned about those different types. Some aneuploid results have a higher potential of potentially leading to a live birth than others. The predictive value of that result might be different depending on those subtypes. The accuracy of a whole chromosome aneuploidy is typically quite high. It's never going to be 100%, but compared to a segmental aneuploidy, I do think that accuracy is much higher. That is where patients need to be informed about those types of things and especially what their clinic's policies are. There are certain patients who, when they hear that the test is never going to be 100% accurate, will not want to move forward because they would want to give every embryo a chance unless there's 100% certainty, and they should be able to make that choice. There are other patients who are quite happy with a 98% accuracy for a whole chromosome aneuploidy and would be comfortable discarding that embryo. But when we are calling all embryos with an aneuploidy abnormal and not getting into that nuance, I think that's where we can sometimes see a decrease in live birth rate with PGT-A when we wouldn't have that information otherwise. If embryos with mosaic results aren't transferred, if embryos with segmental aneuploid results aren't given a chance, we wouldn't have had that information otherwise, and patients aren't given an opportunity to understand what those results could mean and make an informed decision about how they want to proceed with those results. My dream world is every lab has a blinded non-selection trial so that we can know what their specific results mean in terms of clinical outcomes and whether or not their categories are clinically significant. The ones that are not clinically significant are not reported, and the ones that are reported. And I think that is how, in a perfect world, these tests would be done, because there is some research that has been performed in that way that shows that low-level mosaic results have equal outcomes to embryos with euploid results. And those are the studies that have been done in a way where there's less confounding variables to some of the research where we're saying that mosaics have lower reproductive potential. So it becomes hard to know if these results are significant and how significant they are. So I think if we truly know that it is a helpful tool to know about mosaicism, then we should report it and use it to help prioritize. But if like a low level mosaic result is not significantly different from a euploid result, we should not be using that information for clinical decision making. Maybe just high level mosaics are reported because that is a technically clinically significant different category. If we do our job in the informed consent process and inform patients that this is a test about chance of an ongoing pregnancy rather than predicting the health of the future child, we would be able to mask those low level mosaic results, because that 1% chance of persisting mosaicism is relatively low. Most of the time when I'm speaking with patients and I'm telling them about that chance when they're thinking about transferring a mosaic, it is dramatically lower than what they thought it was going to be coming in. They think it's going to be a 50% chance that it persists. And so when I can give them those statistics, it is almost always in a range that they feel comfortable proceeding with, especially when we can compare to things that happen in a unassisted pregnancy. Even with a euploid embryo, you can have genetic conditions that are not detected. This has not been the point of PGT-A, to predict health concerns. And so if that's not the point, then that shouldn't be part of the discussion in the first place. With PGT-A, in terms of assessing the clinical utility, it should be about the ongoing pregnancy rates per embryo transfer. I think there's been a focus on kind of cumulative pregnancy rates, and that's never really been the point of PGT-A. It has always been about single embryo transfer and the chance of success for that individual embryo. So I think that should be the main focus. Additionally, I think the reduction of miscarriage rate is another factor that can be quite helpful for individuals. And those would kind of be the big two that would be on my radar. This is really where, I defer a lot to my embryology colleagues, but in practice, I don't have a lot of evidence to suggest that it does, as long as it's done by a well-trained embryologist in a well set up lab environment. I recognize that if those things are not in place, there certainly is potential, but I think we have enough experience with PGT-A now and enough success with embryos that have had this testing done that we would have seen something by now if overall there were going to be concerns with this process. I think it depends on the patient. I think still in my ideal world, it would be a per patient decision so that they could understand the pros and cons in their specific patient population. And based on their own history and based on their thoughts about the complexity of the test results, their clinic's policies in terms of embryos that they're going to consider for transfer. I don't love the idea of just broadly recommending it for everybody or broadly recommending it for nobody. I think that patient autonomy is something that I really value. And so I think each patient should be able to make that decision for themselves. Pre-test genetic counseling from somebody outside the laboratory is going to be the best way to accomplish that. A group setting can be a good way to do that. I think for people who are really struggling to decide with that, a one-on-one genetic counseling session with somebody outside the laboratory can help facilitate those decisions if they're really struggling as well. The future of PGT-A, again, we would be getting informed consent from somebody independent from the laboratory. I think we're not talking enough about kind of the integration of SNP testing with NGS testing together. I'm not so much thinking about the future because I'm not big picture enough, but I think I'm really excited about what is here already with PN testing. The availability of having an embryo that may look like it's 1PN or 3PN or 0PN and being able to give it a chance, grow that embryo to the blastocyst stage, test it with PGT-A, and see if it actually is 2PN or not. I think we could be discarding viable embryos by just doing a visual PN check. We have the genetic technology to see if that's true or not. I hope that more embryology laboratories are taking advantage of that technology and giving those embryos a chance, because I've seen euploid embryos that did not look like they were 2PN under the microscope. So that's what I'm excited for that's already here.